Perfect. So if you are ready, we can just start and off we go.
Yes.
Okay. Thanks and good webinar to all.
Thank you.
Good afternoon, everyone. On behalf of MYELOMA Health, CME provider of the event, I welcome you. This webinar, entitled 50 Minutes on Multiple Myeloma, is the third appointment of an ECM project consisting of 3 webinars. At the end of the 3 webinars, last October 17th, last October 24th and today, all learners will receive by email the instructions for completing the questionnaire and the relative satisfaction survey. The training credits assigned to this project are 4.5. We would to point out that through the questions and answers section, you will have the possibility to ask questions live at any time, and the possibility to put a like on those that you consider most interesting, in order to establish the priority of the answers. Thanks to all of you for your participation, to GSK for the non-conditioning support it provided to the project, and to Dr. Roberto Mina for the precious scientific direction of the entire project. Professor, to you the word. Good job, everyone.
Good afternoon, everyone. Welcome back to this third and last webinar. Today, we will focus on BCMA as a target and BCMA targeting therapies. It is a great pleasure to introduce you to Professor Sagalonio, Professor of Hematology and Chief Medical Officer of Winship Cancer Institute, Emory University, Atlanta. Professor Lonio, thank you very much for accepting our invite.
Thank you. Good to be here.
So today the topic is BCMA and BCMA targeting therapies. Just to give you an idea, we now have approved in Europe 4 different drugs. We have ide-cel, we have cilta-cel, we have belantamab, and now we also have teclistamab. In Italy, we have available belantamab. We are going to have soon probably ide-cel, waiting for cilta-cel, and we have used teclistamab as a compassionate use. It's not available commercially, but hopefully will be in the future. So we are getting used to use these drugs, and so it will be very nice to hear from you data that led to the approval of these drugs, and then it will be great to also discuss on their use, practical points, and also their application in the future. So please, if you want to take the stage.
There we go. All right. Thank you. All right. I couldn't figure out how to unmute after a year and a half. All right. Well, thank you again very much. And it's great to be here in front of this audience and looking at the agenda for your previous programs. It looks like it's been a great series. And again, appreciate the opportunity to be here. What I'm going to talk about in the next few minutes is really about BCMA targeted approaches as you introduced. And when we think about BCMA, I think it's important for us to recognize that BCMA is not only a new immune target when it comes to multiple myeloma. So we've already got CD38 and we've got SLAMF7 as immune targets, but BCMA in and of itself is really responsible for many of the things that plasma cells like to do to stay alive, particularly when they're transformed. So when we talk about proliferation of plasma cells, when we talk about stromal binding of plasma cells, and when we talk about drug resistance of plasma cells, many of these are linked to BCMA and their potential ligands, APRIL and BAFF. And so interrupting BCMA signaling simply by binding BCMA actually may have a very anti-myeloma effect when you couple it with highly effective therapies like antibody drug conjugates that you see down here at the bottom, bispecific antibodies or T-cell engagers that you see in the middle, or CAR T cells that you see at the top. It really does represent a pretty substantial therapeutic opportunity right now in the context of refractory myeloma, but typically, as we do with everything else, it's moving earlier and earlier and will likely have greater impact on our outcomes. Now, one other quick story, and this is gonna come up in one of the slides that we're gonna talk about in a few moments, is the role of an enzyme called gamma secretase. And the reason that gamma secretase is important is that gamma secretase cleaves BCMA off of the plasma cell and releases it into the serum or the plasma. And when it's there, it can serve as a sink to bind other BCMA-targeted agents. But at the same time, it also potentially gives you an alternative way to assess tumor burden. So we know that over time, some patients with myeloma lose their M protein or lose their light chain. Soluble BCMA may be another way to potentially measure tumor burden, and inhibition of that cleavage off of the plasma cell may also ultimately be important to increase expression of BCMA and make BCMA-targeted agents even more effective. Now, the first agent we had approved in the context of BCMA-directed therapy was belantamab mafodotin, or belamaf. And this was approved on the basis of the DREAM-2 study, where the overall response rate was 32% in our median of 6 to 7 prior lines of therapy. The median PFS was about 3 months, which is typical for any drug in refractory myeloma with a response rate of about 30%. But more importantly, the DOR, the duration of response, was about 11 months. And the reason that I'm really focusing on the DOR is that we know that PFS is a marker of an entire population of patients. But what DOR really tells you is safety in the context of responding patients. And the reason I bring that up is if you look at a drug like carfilzomib, you look at a drug like daratumumab, you look at a drug like pomalidomide, their median response rate in relapsed and refractory myeloma, 25 to 30%. Median PFS was 3 months. So similar to what I've showed you with belamaf, each of their median DORs was somewhere between 7 and 9 months. What that means is that for many of these drugs, they're safe enough that you can keep the patients on who are responding long enough to gain greater benefit. And this to me is really important because there are other drugs that we use in refractory myeloma that have 20 to 25% response rates, PFS of 3 months, but median DOR is only 4 months. And so I think we need to be very careful about understanding what DOR tells us. And in my mind, it's an amalgamated endpoint between safety and efficacy. Now, we all know that, that keratopathy is probably the main side effect that we see with belantamab mafodotin. And what you see on the left is sort of a visual description of the severity of some of those symptoms over time. What I think you'll notice is that if you look at all 95 patients, 68 of them had some form of keratopathy that was picked up by an ophthalmologist. So this doesn't necessarily mean that they had symptoms. It doesn't necessarily mean that it impacted their vision. It was just picked up on a routine ophthalmologic exam. However, if you get to the slightly darker purple circle, you'll see that 53 of those 95 patients actually had some form of symptoms, the most common being dry eyes, slightly blurred vision, or itchy eyes. And it wasn't really until you got down to this area here where you can see that only 18% of patients had a change in their visual acuity of 20/50 or more. Now, for those of you who are like me and don't remember ophthalmology from medical school, 20/50 or more change is 2 lines on the Snellen eye chart. So if you had a change of 2 lines or more, that gets you a change of 20/50 or more. And as you can see, that only occurred in 18% of patients, or 1 in 5. And if you look at grade 4 here, you can see discontinuation. Only 3% of patients had to discontinue because of keratopathy. Now, of note, One patient actually did develop grade 4 keratopathy, meaning that they had an ulcer in the cornea. That patient ultimately resolved that keratopathy and was retreated down the road at a lower dose. So even the development of grade 4 doesn't necessarily preclude ongoing treatment if the patient remains stable or deepens their response. And that really speaks to the table on the right. As you can see, most patients who got belamaf and had to have substantial dose holds actually maintained or deepened their response over time. And I think that is important because I think this clearly does speak to some important take-home messages in terms of communication we have to have with our patients. Now, the next drug that was approved that targets BCMA is ide-cel, which was the first CAR T-cell approved in multiple myeloma. This is a BCMA-directed CAR T-cell. And again, the dosing was pretty standard. There was a dose escalation. And what was determined was that at least 2 of the doses were highly effective. And in the KARMA study that led to the FDA approval, what you're seeing on the left is the response rates in refractory myeloma. And certainly where I just showed you a response rate of 32%, here we're seeing response rates overall of 70%, 81% at the highest dose. And more importantly, we're seeing very long progression-free survivals that, as you might expect, are dose-dependent and honestly are depth of response dependent. Patients who achieved CR had a longer progression-free survival than patients who had an MR or no response at all. And I think this really has been a major step forward for us in the field, because having a CAR T-cell obviously is very important, but more importantly, these high overall response rates and long PFSs are certainly really good news for our patients. Now, the next CAR T-cell that was ultimately approved was cilta-cel. This is based on the CARTITUDE-1 study, and structurally, cilta-cel is a little bit different. It has 2 BCMA binding domains on the antibody portion of the receptor here. Again, similar lymphodepletion strategy, similar study in terms of design. What you'll notice, however, is that the cell dose is significantly lower. And that is important, and it'll come up as we talk in a few moments when we start talking about timing of cytokine release syndrome, or CRS. Now, when you look at responses, again, this one is 97.5% response rate, even higher than what I showed you for ide-cel. Median progression-free survival has not been reached with over 2-year follow-up now. And median overall survival, particularly for deep responders on the right side, is really, really good. Outstanding data, again, suggesting that CAR T-cell-based approaches are really going to be a substantial change for our patients over time. And this, to me, is really exciting. It's really encouraging data. And I think what we're waiting to see is whether there is a plateau on these curves, because in CD19-directed CAR T-cells with both lymphoma and acute and ALL, you can see there are clear plateaus in those PFS and overall survival curves over time. We've not seen that with a CAR T-cell yet, but we may not have had a long enough follow-up in CARTITUDE to really know whether that, in fact, is the case. Now, in terms of adverse events, they are somewhat similar between the two. This is the cytokine release syndrome, or a CRS, and ICANS syndrome, which is the neurotox between these 2 approved CAR T-cells. You can see the rates of CRS are relatively similar, but the timing is very different. Ide-cel tends to occur relatively quickly, as you can imagine, with a higher cell dose. Cilta-cel takes a little bit longer, closer to 5 to 7 days, because you give a lower dose and you need in vivo expansion before you ultimately get things like CRS or ICANS. If you look at severity of ICANS, you can see here grade 3 or grade 4 is really low, 2 or 3%, compared to what we're used to seeing in CD19-directed CAR T-cells, where that number can be 20% or even higher. The way that I think about BCMA-directed adverse events with CARs is that on average, it's 1 grade lower than what we see with CD19-directed CAR T-cells. So whereas you get grade 3, grade 4 at a much higher incidence, the average grade in BCMA is about 1 grade lower. Again, infections are an issue, and I'm sure Dr. Mina and I can talk about that during the discussion. There is important prophylaxis. And then again, delayed neurotoxicity is relatively low. There is a Parkinsonian-like delayed neurotox that was seen in the CARTITUDE-1 study. It has not been seen with the same frequency in subsequent studies, and so maybe a tumor burden-related issue as opposed to a true major adverse event associated with a BCMA-directed CAR T-cell in general. Now, how can we make CAR T cells better? This is coming down the pike. This is the Novartis PHE 885 in relapsed refractory myeloma. This is a CAR T cell where you leukapheresis on a Monday and you potentially give the CAR T cell back on Wednesday or Thursday. So you don't need to think about bridging. The inherent selection bias in CAR T cell trials because of the 4 to 6 week wait for those production and manufacturing may be less of an issue with a rapid turnaround. And this is one way that we're trying to get around some of the challenges that we have with manufacturing in the context of CAR T cells in myeloma. And the last of the CAR T cell things that I really want to briefly touch on is this idea of using a gamma secretase inhibitor. And the reason I'm bringing this up is the group from Seattle at the Fred Hutch Cancer Center actually gave a BCMA-directed CAR T cell with a gamma secretase inhibitor and showed a very high overall response rate. And in fact, many of those patients had been exposed to prior BCMA-directed therapy before they even came into this study. So this may be a really important strategy down the road, and it's being looked at not just in CARs, but also being looked at in the antibody drug conjugate. I reported data at ASCO with belamaf and a GSI, where we demonstrated that you could drop the dose of belamaf by having higher expression of BCMA, and that resulted in similar or lower rates of keratopathy. So I think there's lots of hope for this GSI concept, especially since many patients who relapse after BCMA-directed therapy don't lose BCMA expression, but they may have lower BCMA expression. And so using a GSI may be a way to try and salvage those patients over time. Now, I'm going to wrap up talking about bispecific T-cell engagers. And this is really important because I think, as you heard from Dr. Mina, this is now approved both in Europe and in the US. Really exciting and important data. And more importantly, this is a new concept for us because we haven't had bispecific T-cell engagers in myeloma. And what it really takes is a portion of the FC fragment that binds CD3 with a portion of the FC that binds BCMA and puts it together into a new antibody. So you get an antibody that binds both a T cell and a myeloma cell, brings them in close proximity to each other, and that activated T cell then kills the myeloma cell. So this, again, has worked with CD19 and CD20 in lymphomas and ALL, and certainly we are very excited about this data in myeloma. And the first approved BCMA-directed T-cell engager is teclistamab, based on the MajesTEC-1 study. As you can see here, weekly teclistamab given subcutaneously after the step-up dosing, and then patients stayed on therapy for as long as they had a response. And what I think was quite impressive was a 63% overall response rate, with about 39% of patients achieving a CR or better. Again, major responses seen in a median of 5 to 6 prior lines of therapy, triple class refractory, end stage myeloma patients, and by many estimations, really these responses were quite striking because we didn't have that delay. We didn't have the time to produce the product. It was an off-the-shelf treatment that could be given relatively quickly. And if you look at durability in the swimmer lane plot here, what I think you're seeing is that many of these responses are quite durable over time, which is really exciting and encouraging, I think, for our patients as well. If you look at the median PFS in the phase 1, phase 2 study, you'll see it's about 11.3 months. Again, median overall survival was about 18 months or so. And a lot of this is being driven by those non-responders. And again, as we bring it earlier and earlier, will we begin to see better and deeper responses and potentially even longer progression-free survival? The DOR point that I mentioned earlier, 18.4 months DOR. Again, this data is not very mature with a median follow-up of only 14 months, but certainly suggests that this is a safe treatment to give. And as I mentioned, DOR is a balance between efficacy and safety. I think this is really encouraging data for a T-cell engager. Now, if you look at overall adverse events, there was a little bit of hematologic toxicity that we saw here. Not really a big surprise. CRS did occur. Any grade was 72%. Grade 3, grade 4 was only one patient that developed grade 3, grade 4 CRS. And more importantly, to me, again, if I mentioned that BCMA-directed CARs are on average 1 grade lower than CD19, the bispecifics are on average 1 grade lower than the CAR T cells. So in general, this is pretty manageable, but does require some form of step-up dosing in order to ultimately be more effective. Now, infections were an issue. We'll talk about that again in the Q&A. Here is the absolute CRS data. You can see here, grade 1 for a majority. There were a couple of patients that had grade 2 CRS, almost all managed with either tocilizumab or a single-dose corticosteroids. Only one patient needed a vasopressor and needed some level of more intensive ICU-level care over time. Again, nobody really had grade 3 or higher cytokine release syndrome. If you look at the neurologic toxicity here, again, all neuro were grade 1 and grade 2. There was one patient who did have a seizure on teclistamab, but this was in the context of bacterial meningitis during cycle 7, and again, brings up the infection prevention and prophylaxis question that I think is really important, because you get profound suppression of plasma cells and B cells during the treatment period with teclistamab over time as well. Now, as we know, there are a number of other T-cell engagers that are certainly in development. You can see some of those listed here. And the main difference in my mind is about dose, route, and schedule. I suspect that these are all going to be functionally very similar. There may be some minor changes here and there, but I think they're all going to be somewhat similar. And again, what we need is longer follow-up and more studies to really understand how they compare head-to-head with each other over time. So with that, I'll stop and turn things back over to Dr. Mina, and happy to take questions as well.
Thank you, Dr. Loniel. So thanks for the great presentation. I think it's a very exciting time in myeloma. As you mentioned, we have 3 drug classes, great results. So first, I would like to touch some practical aspects. Assuming we have all 4 products available, and since we don't have any head-to-head comparison, in your practice, is there any patient characteristic or disease characteristic that you would pick up a treatment or not?
Yeah, I think one of the questions that often comes up is, with these really high overall response rates, with the T-cell engagers and the CARs, is there a role for belamaf? That's been posed to me a number of different times. And my response to that is, I have patients who want to take low intensity therapy, don't want to be in the hospital, even for step-up dosing. And for those patients, or are frail or have severe heart failure or other issues like that, where the volume that you might need to give them to get them through CRS may be a challenge. And so for those patients, belamaf might be a very reasonable opportunity for them. It's a purely outpatient treatment. You come once every 3 weeks. The heme toxicity is pretty manageable and pretty marginal, particularly in patients with good count. So I think when I think about patient characteristics, I do think about frailty. I think about the need for immediate therapy. And I think, there are some patients who that there's no way you're going to get them to a CAR. They don't have the luxury of waiting for the pheresis slot and waiting 6 weeks after production. Those are patients you may go more towards a T-cell engager. And I don't think it's a zero-sum game in the sense that you can only get one. Unlike CD19-directed therapy, we know that BCMA loss is relatively uncommon, probably occurs 5% or less of the time. And so I've had patients who, for instance, got belamaf, then ultimately went on to get a T-cell engager and or a CAR T-cell, or vice versa. So I don't know that it's only a one-size-fits-all. I think you're going to get lots of different opportunities based on the patient in front of you.
Yeah, so you're saying that patients who have a very rapid relapse, maybe with extensive bone marrow invasion, that may not be able to be CAR T eligible, or frail patients. And I agree with you completely. And I would add another factor in this, which is logistics, because we are a little less lucky than you in the US, but we have limited availability for beds. It's not really easy to get a patient hospitalized in a timely manner. So I think that's also a factor. The patient the disease may not be able to wait for the CAR T to be manufactured, but sometimes also we have that kind of issue. We have a lot of hematological centers that are tertiary centers that do not have an inpatient. So in those centers, CAR T is not an option, bispecifics are not an option. Patient must be referred somewhere else. This is not always easy. I mean, it's easy if the patient has a biochemical relapse, but not if the patient has a very aggressive one. So that's something that we have to deal with every day. And so another thing, you touched it briefly. It may not be a one treatment only, maybe sequencing. I know there are some data, some limited data with T-cell engagers after ADC, after CAR T. There will be data presented at next ASH with IDESA or so after MYELOMA or T-cell engager. What do you think? Do you think that we may somehow? What are your thoughts about sequencing?
Yeah, I think it's really interesting because when we think about resistance to a drug, I think CAR T cells are going to sort of change the way that we think about that. And the reason I say that is if somebody is progressing through a CAR T cell within 30 to 60 days of infusion, that definition of relapse is different than somebody who relapses at 12 to 18 months after a CAR T cell. And the reason I say that is that the second case is likely a failure of persistence. So they are likely going to re-respond to a BCMA-directed therapy, whereas the first one is likely either the T-cell product was not very good or the microenvironment simply didn't allow for a CAR T-cell to be effective. And in that patient, I don't know that a bispecific is necessarily going to work, whereas an ADC might, because you're bringing in chemotherapy as opposed to immune-dependent mechanisms. So, when I see patients who are relapsing after a CAR at 12, 15, 18 months down the road, I don't have any second thoughts about whether I'm going to think about a T-cell engager or belamaf in those patients. And so I think that there's just a lot of play. And just as you described, access is an issue. Even if you wanted to give everybody a CAR, you can't give everybody a CAR. I mean, at our center, which, as you remember, was very busy, we get 4 CAR T-cell slots a month. We have 80 patients on the wait list. And so not everybody's ready to go when the slot becomes available. And so I think from a practical perspective, a lot of this is going to boil down to T-cell engager versus belamaf as first shot until you have more time to get them access to a CAR down the road.
And do you see this sequencing approach as something that will be studied, or since we have GPRC, 5D, FC, do you think we're just going to move on, or do you think we may have to study this a little bit better?
Well, I hope we get to study it a little better because I think the mechanisms of relapse and resistance are going to be different. My guess is that for belamaf, it's going to be more chemotherapy-related mechanisms of resistance, whereas with a T-cell engager, if you have poor T-cell health, and I always laugh when I say that because everybody says refractory myeloma has poor T-cell health, and yet you get a 70% response rate with a T-cell engager, right? But I think that when you've got lots and lots of active disease, the harvested T-cell for CAR T-cell production is going to be less effective. And at the same time, the ability to maintain a response over time with a T-cell engager may be lower as well. So I just think there's so many variables we need to spend time to understand so that we're not rolling the dice on which one is going to work. We can predict which one is going to work, and immune profiling is going to be important for that.
All right. So another comment on belantamab, for example. So I think that, as you mentioned, the toxicity, so the duration of response is very promising, and it tells that patient can stay on treatment despite delay, despite those reductions, but still the response is there. So, and to me, that means that probably we have to work on the schedule, on the dose, but I also think that, so we have a proof that that drug works as daratumumab worked. So 1/3 of patients fine, but then daratumumab were very quickly moved up front. So, and combining it with something else, it means that we may reduce the dose more. We're more confident in using a lower dose, also a schedule less intense. Do you think this could actually lead us to an improvement in the results?
Yeah, no, I think you're absolutely right. And we've seen some hints of that, for instance, in the Algonquin study, when belamaf was combined with pomalidomide and the response rate jumped in relapsed and refractory myeloma. We've seen some hints of this in combinations with, and the dose and schedule were different in the POM combination. We've seen some examples of this as well with lenalidomide, where we're seeing early induction therapy, we're seeing changing in dose and changing in schedule that are really translating into better efficacy and better safety as well. And then I really think that the GSI story is going to be important for belamaf, because what we showed is that we can give a much lower dose. We get a similar response rate in refractory myeloma, but that the keratopathy rates are significantly lower as well. So I think combining with other drugs, moving it earlier, changing the dose and schedule, and adding in a GSI, I think these are all going to be variables that are going to make a belamaf-based approach a little bit easier for patients down the road.
Speaking about instead TCEs and CAR-Ts, so we've seen that with CAR-T exceptional responses, of course, getting a CR is always better than not getting a CR, but it really makes a difference. And achieving, so most of the patients with ide-cel did not respond to bridging therapy. Some patients with cilta-cel instead responded, but then still the PFS is outstanding. So probably moving these drugs in earlier lines when you have a bridging therapy, which is very, very effective, such as we were seeing now, it really may extend this, and really may switch the treatment paradigm of myeloma, rather than having continuous treatment for years and years. It might be one shot and then be done for many, many years. But then you need alternatives, such as like an anti-BCMA, again, as you mentioned before. With TCEs instead, now they're approved until progression, but we're seeing a lot of infections. We've seen very, very high rates of infection. So I'm sure you read the article on blood of intermittent dose. And so do you think that we should probably use these drugs in a smarter way, rather than just give them until progression, in order to maximize efficacy but not jeopardize with safety?
Yeah, no, I think you're absolutely right. We published in JCO that the patients who don't seem to respond to the COVID vaccine are patients who are on DARA or getting BCMA-directed therapy. And so even the idea of continuous DARA forever is something that I think we have to revisit, because there are clearly those really deep and long-term responders. I mean, the first patient I put on the MAIA study is now 8 years out and getting monthly DARA. Does she really need monthly DARA? I don't know. And certainly with the T-cell engagers, continuous therapy becomes a really challenging model because of the infection risk and all the other potential complications. I mean, these patients are reactivating CMV, reactivating EBV, getting other unusual fungal infections or cryptococcal infections. I think we have to figure out not just a way to prophylax them. I like the idea of intermittent dosing. I think the concept of sustained MRD negativity is probably more livable in a T-cell engager world than it is in a non-T-cell engager world. But I do think 10 to the minus 5 is not the right endpoint. I'm a strong believer that 10 to the minus 6, 12 months apart, with a minimum duration of 12 months is really the answer. So I think if we're talking about 2 years of therapy with a T-cell engager, I would be comfortable with that. But we need to understand what those curves look like. We can't do the continuous treatment mantra anymore.
Yeah, and I think this becomes very relevant when we're moving from lenalidomide, which is a relatively safe drug, rather than to a TCE, which is super effective, but also can be right. So,
I will say, I think the mechanisms are different. So with Len, it is really cytostatic, whereas we know the T-cell engagers are cytotoxic. They kill the cells, right? And so I think with a cytostatic drug, you have to have continuous therapy. With a cytotoxic drug, I don't know that you do. And so I think we need to think about biology.
Sure. Another thing is, practically, how do you manage toxicity of these agents, particularly the keratopathy and the CRS in the inpatient when you start step-up doses?
Yeah. So in terms of keratopathy, the best thing you can do is supportive care, which is preservative-free lubricating eye drops. Telling patients there's not a lot more you can do in terms of prevention there. Steroids were tested and did not appear to offer significant benefit. One of the things that we ran into is I had a patient that had a great response, but for some reason at 10 and 12 weeks out, they were still reading it as grade 3 keratopathy. And so finally we called the ophthalmologist and said, what are you seeing? And what they said was, well, the visual acuity is still not where it was at baseline. And so we said, well, why? Because the keratopathy should be better at 12 weeks. And they said, oh yeah, the keratopathy is gone. It's cataracts. And so cataracts occur in our patients, right? I mean, these are things that happen. Corticosteroids predisposed to them. Maybe they were looking at an angle one way and they weren't looking at an angle. And so the cataract was having a greater impact. But I think it's important to recognize that what we're really focusing on is a reversible side effect. And if you're not seeing that reversibility, then it may be something else. It may not necessarily be keratopathy that's the problem. In terms, I think your second question was about infection, right?
Also the CRS, in
CRS.
terms if you're like on the prevention side or not, and then infection.
Yeah, I think a lot of us are using tocilizumab for what is functionally grade 1 CRS to really try and prevent the progression to grade 2 CRS. I don't think there's a downside to giving tocilizumab, particularly since many of these patients, when they spike a fever, are already being put on antibiotics. So you're doing the things that you would do anyway. And so you could argue giving anti-IL-6 may block the fever response, but you're already treating them for a fever. So I think early administration of tocilizumab, aggressive hydration, I think CRS management with the T-cell engagers is really not a big deal overall. I think in terms of infection prophylaxis, we put all of these people on PJP prophylaxis pretty early. We all give them monthly IVIG. Here, we're giving them Evusheld, which is the COVID antibody as well. In addition to, any hint of something funny. I had a woman who at day 30 dropped her counts and it turned out it was HHV6. And so we ended up giving, again, lots and lots of IVIG. Her blood counts came back up over time. And so I think there are lots of things that we need to look at to make sure we're preventing infections in these patients that really are pretty prone to infectious complications.
So in the previous webinar, we were discussing with Professor Bexak, which I think is also here, and hi, Mara, about extramedullary disease. And what we were discussing is that with all these agents, despite their efficacy, we still see lower responses in patients with extramedullary disease. Do you have any idea why is that? Do you think like for CAR-T could be a trafficking issue, the immune system, which is different in the extramedullary side rather than the bone marrow, or anything else?
It's interesting. If you look at both CARs and T-cell engagers, having extramedullary disease does predict for a shorter response. But one of the things that really struck me, the first ide-cel patient I treated had a 5-centimeter plasmacytoma on the forehead, and within 24 hours of the infusion, it was gone. So I don't think it's a response issue. I think it's a durability issue. I think it's when you get extramedullary disease, these cells are independent of the bone marrow microenvironment. They are intrinsically more resistant. They are harder to eliminate. And this is where I think persistence becomes a bigger issue. We know that CAR T cells in myeloma last on average 3 months, and it's not uncommon to see a relapse at 4 and 5 months when the CAR T cell persistence is starting to go away. And these are patients that I wonder whether giving a CAR to rapidly debulk and then putting on a short duration of T cell engager as maintenance may be an optimal strategy to try and sort of make up for that lack of persistence, particularly in a high-risk phenotype like an extramedullary disease.
Yeah, in this sense, do you think that, so many of the patients enrolled in the KAMA study and the CARTITUDE study had to have bridging therapy because they're the disease itself. But do you think that in the future, particularly if we treat a patient with a biochemical relapse, it really does not need bridging therapy, but do you think bridging therapy could actually help in reducing toxicity and maybe increase the efficacy? So do you think we should give, if we have the possibility, bridging therapy to have the lowest tumor burden possible when we infuse with CAR T or we use bispecifics?
I think the question about bridging therapy really in part is dependent on what you're going to use. If you're going to use a cytotoxic agent like DSAP or VDT PACE or something like that, you may actually ultimately end up doing more harm than good in terms of suppressing immune function and making it more difficult for the CAR T cell either to be effective after apheresis or be creating an environment where it's more challenging for that CAR to be effective in the post setting. If you're going to give something like an IMiD, that might actually be effective. That might work. So I think it depends in part on the choice of bridging therapy. I think it depends on the toxicity of that bridging therapy that you're giving, because obviously the more you beat up the patient, the harder it's going to be to ultimately come out of a CAR on the better end. But I agree with you, less tumor burden is likely to result in less CRS and less neurotoxicity, and that ultimately may be the better platform on which to deliver a CAR T cell.
And which do you think are or could be the best partners for all these drugs, and in terms of drugs that we have now? Should you combine after, for example, CAR T or during bispecifics or MYELOMA?
Yeah, I mean, I am a big fan of the IMiD and CELMoD class of drugs in terms of being a partner and an enhancer for immune reactions. And just as an example, in the last 2 patients I've treated with a CAR T cell, we've now put them on POM, even though they're POM resistant, at about 90 days out to try and improve persistence and maintain that anti-tumor response even longer than the half-life of the CAR T cell. So I think, to me, that makes almost the perfect partner for many of these approaches, both a bispecific or a CAR T cell. I think the 1-2 punch of a bispecific and a CAR T cell together as part of a planned treatment approach also makes a lot of sense, and in a way to try and get sustained MRD negativity, particularly in an early relapse patient, and then stopping so that you don't have all those chronic infection and other complications that occurs over time.
So speaking about the development of these drugs, how do you see the development of CAR Ts and ADCs and T-cell engagers and in the next 5 years, let's say? How do you foresee the future?
Well, my hope is that the standard approach of we're going to do not just a quad, but we're going to use 5 drugs, or we're going to use 6 drugs as part of induction. And we're going to take the same consolidation and then maintenance approach that we've done for the last 20 years. I don't want to see that. What I really want to see is us taking these 5 now immune targets and combining them together as part of a modern total therapy approach with defined treatment, MRD-directed changes in treatment, and then stopping treatment at some point and allowing to see whether we're actually increasing the cure fraction. We know, and I think you saw many of these patients with us who were 10, 15 years out from an auto transplant with RVD induction, single agent len maintenance, and we're doing really well. That's great. How do we increase that fraction of patients to 30, 40, 50%? If we can't do it with the immune targets we have now, then we're simply not thinking hard enough, because I think with all of these drugs, we should be able to put them together in an approach that prevents drug resistance and clonal escape, but also shortens the duration of treatment.
Yeah, no, I see your point. And I think that with better drugs in terms of efficacy, but also with somehow more side effects, at least early on, we should really limit treatment duration. And I think it's also extremely exciting to see patients that are off CAR T treatment-free interval. This is something really, for me, is stunning, because you see those patients that have been for many years on therapy, continuous therapy, and now all of a sudden you see out of treatment, live their life, and it's I think it's very exciting. So I think Maral just asked a question, which is, how's your approach, immune approach, for patients with CNS disease?
Yeah, this is really challenging. There's not easy ways to get around this. And we know that patients with CNS disease, at least in theory, are not eligible for CAR T cells because of the risk of neurotoxicity and seizures. So, you know, I think these are patients that we try and treat with intrathecal chemotherapy, unless they've got obviously large masses. That can be effective and clear the CNS in some patients. The problem with patients that have CNS disease, however, particularly meningitis, myeloma meningitis, is that they almost always have disease somewhere else. And so systemic control is a problem. One of the drugs that seems to be able to cross the blood-brain barrier is selinexor. And so thinking about selinexor-based approaches in this context may be of some value, but this to me is one of the most challenging group of patients to treat.
Yeah, and also we've seen these patients in late lines for which you have very limited options. We have some patients who somehow did good with intrathecal treatment, somehow with IMiDs, with daratumumab, but it's really anecdotal, and we really don't have a clear answer for this. So the one thing I would like to ask you: do you think that because we normally say that CAR T patient needs to be hospitalized, ADCs don't need to be hospitalized. For bispecifics, they still do need it. Do you think that prophylactic intervention could be somehow helpful to treat patients with bispecifics as an outpatient?
Yeah, you know, that's an interesting idea. And one of the, you know, as you have, I've certainly heard the data on each of the different bispecifics. And the one question I keep asking is, can you tell me a median time from infusion to CRS? And none of them can do that. And so I think until we have some level of predictability about when that time between first dose and CRS, and sometimes it's not with the first dose, it's with the second dose. You know, I think we need to understand that time frame a little bit better in order to anticipate it and then use an alternative therapy as either a preemptive or a prophylactic approach. I think there are two biologic ways to approach it. The first is we know that high levels of IL-6 can lead to drug resistance, and so preempting CRS may actually make the disease more sensitive. Larry Boyes has been pushing this for a long time, and we know this in venetoclax, that high levels of IL-6 actually make you resistant to venetoclax. At the same time, we have data from lymphoma where giving preemptive tocilizumab, the outcomes were actually worse with CAR T cells. So I think it is something we can't just empirically think, we actually have to test it. And I don't know when you would give it in order to prevent it, because we know the half-life of toci is not really long. So if it's 12 hours and you give it at hour 1, you may miss the effect, right? So I think understanding those medians and times are going to be really important.
So there's another question from Meral, which is, with fludarabine shortage, do you use cladribine, or I would say bendamustine in CAR T as a lymphodepletion?
Yeah, you know, that's an interesting question. And we certainly, as yet, have not had a fludarabine shortage, but this question is coming up a lot in the US as well. I think most folks here are using bendamustine, mostly because the half-life is shorter. The cladribine half-life may be longer, which means you may have to wait longer to give the cells afterwards. I don't know that there's necessarily any one right or wrong answer. I know Tom Martin from UCSF has been sort of championing a total lymphoid irradiation approach as well, which would be sort of chemo-free, if you will. That might have some interest as well, but bendamustine is, I think, what most of us are using. All
right. So I think we are approaching the end of this webinar. And so I would really like to thank you for your participation. I don't see any other question. And so thank you very much. It has been a pleasure. And thank you everyone for attending. And I hope you have a good rest of the day. Thank you very much.
Excuse me. There is a question from Meral Beksak in chat.
I think we just discussed it.
Yeah, okay, sorry.
Thank you, Anna. All right, thank you very much.
Thanks to you.